instantaneously paid out on their mobile devices. Now, two things happen as a result of that. First of all, the central organizers now have access to the mobile network of all of the people in their catchment area, so they're able to provide much more tailored information back to them. And the farmers get payouts in the event of an adverse situation, like instantaneously, which is the big problem with microinsurance, is it just takes forever to get the payouts. So you can start to see these kinds of activities. This is the last one I'll share with you. This is an organization called Ceasefire in Chicago, run by this guy down in the corner named Gary Slutkin. Gary is an epidemiologist from the World Health Organization, and the premise of this anti-violence program is to treat the spread of violence as if it were a human communicable illness. If you look at the outbreak of violence in high violence-prone communities, it looks a lot like the outbreaks of TB, HIV. And so what they do is they train formerly incarcerated guys, many of whom have committed capital murder and are not employable in their local communities, to become informal public healthcare workers. They take 10 by 10 block grids and they interrupt the flow of violence by making informal social network maps. So they know that if Joey shoots Tito, that Tito's brother is going to shoot Joey's brother, and that's going to cause a conflagration that looks a particular way. Now, what we're doing now is bringing guys from Ushahidi, guys from Frontline SMS, a number of other mobile services innovators together with this. And just to give you a sense of what they do, their strategy is basically to interrupt the flow of a deleterious behavior, change the mindsets of the high incident transmitters, and then change the social norms. And the Department of Justice analyzed them, and they lowered the violent crime rate by 75%. But they have no path to scale. So what mobile services allow them to do is to amplify the efficacy of their violence interrupters and bring them to affect a larger area, a physically larger area, to essentially sense what's going on in the community in real time. The last example I'll just share with you is one of my other favorites, my favorite iPhone application of all time. Let's say that you are, I don't know, a heavyset Italian guy. Let's just say. And let's say you find yourself at the donut shop where you really should not be eating that donut. Let's just say. And let's say you're really tempted by that donut. What this particular application allows you to do is take a picture of that donut and instantaneously share it via your mobile device with your entire social network. And your social network then goes, "Don't eat the donut, Andrew," if your name was Andrew. And if you don't eat the donut, they get points. So what we're using is gamification of social change in real time using mobile device to drive self-driven behavioral change for things like obesity, smoking, adherence to medications. Think about all of the healthcare behaviors right here in home that we need to drive. These are the ways in which we're going to use mobile devices in the future. And again, that enormous opportunity is to pull out of that these extraordinary data sets that give us crystalline pictures of behavioral economics. They actually show us what happens in the economy of messages, behaviors, and outcomes. And that's really why these mobile devices are so interesting. So that's it.
Thank you, Andrew. That's fascinating. Changing behavior, personal behavior, what about changing institutional behaviors? And I want to hear from Christopher on how some of the work in the field is driving change at UNICEF. I mean, some of these new patterns and all of this new data. What about the institutional change? Do you want to speak to that a little bit?
Yeah. Well, I have the luxury of not having slides, which means I can both sit here but also be adaptive to some of the things that have been brought up already. And so I'd like to talk about that institutional change, but through the context of how one of these projects can be built. And I think since there's a lot of discussion about health, maybe I'll just tell you a short story about a project that has to do with both of these two and how it came to be where it is. In Malawi and in Zambia, there's this endemic problem of lack of health professionals for people. There's also, in all of the countries that UNICEF works in, the largest volunteer force in the world. We don't know how many they are, but they are community health workers or health extension workers. And they're mostly unpaid and lightly trained. In Zambia, about a year and a half ago, we had a question from some of the UNICEF health people in our country office. And the question was basically, if we're getting results, if we're getting children who are tested in northern Zambia, and they're being tested as infants for presence of HIV, if those results have to go to the city, the capital city, which is 12 hours away, and have to come back, and if that cycle takes really 6 months once you get these dried blood spots on a motorbike, and then you get it into a bus, and then it gets tested on a big machine, and then it gets sent back to the where the health center where the test was done. And if you give that infant medication after 6 months, they're going to be dead. It doesn't really matter at that point. You need to get to them before that. The question was, is there any way to do this better? And this is a project called Project Mwana, M-W-A-N-A. It has the same first letter as Masiluluki, and it actually has a lot to do with it. And so I want to just preface this story with 4 postulations based on what we've seen. One is that these projects have to be based, any mobile project has to be based on actual user behavior. It can't be built in the US and then shipped to northern Zambia. It can't even be built in northern Uganda and shipped to northern Zambia. It has to be built with the users, and the users are not UNICEF health people, and they're not the Ministry of Health people. They're the health extension workers. They're these people at the furthest edge of any of our systems. You have to sit with them and build systems that work for them, and so it's an iterative design thinking kind of principle. The second postulation is that these projects must be open source at a very fundamental level, not just that the code is out there, but that people are actively sharing in an egoless fashion what they learn and what they fail at with each other. Frog, which worked on that project, is also working with UNICEF, and 80% of what they learned in South Africa as design thinking, they can apply to a UNICEF project. And that means that we're a tremendous amount further ahead than we would be if we were trying to build something in a silo the way that it's traditionally kind of done, and that this is my thing, and it's going to have my name on it. That's the second postulation. The third one is that these have to be monitored. There has to be an open monitoring and evaluation component to these projects, because it's so easy to have a pilot health project that you get this, as Andrew was saying, post-monitoring, a report that's done 2 years later and it looks really good. There has to be active real-time monitoring of these projects to show transparency, but also for us to sort of adjust to our mistakes. I think that was all 4 of them: locally, open source, user-centered, and monitored. The way that we're doing Project Mwana in Zambia is as follows. We have a problem. Problem is, how do you get these test results back more quickly? There's a set of users, these community health workers, who are maybe trained for a day or 2 days or 3 days, and then they're sent back to their communities and asked to perform fairly advanced diagnostic tests on children. We sent a team of 2 people from our team in New York to Zambia. Sitting in the capital, they trained up 3 local developers, computer programmers from Zambia, in the open source platform that they would need to use to build any of this. And it's a simple platform. It's an SMS-based platform. It's all running the same stuff. It lets a basic mobile phone, the Nokia 1100, which is the gold standard of the whole world, it lets that phone communicate with a computer somewhere there's internet connectivity, and it lets people move information back and forth. So you have these 3 local developers who are trained. But I don't know if everybody here has worked with engineers and hackers and programmers. One of the things that they're really good at is building complicated things. One of the things that they're very bad at is making things that work with users. So the second part of this project was, how do we get user-based design thinking into this health space? Through a partnership with Frog, we said, look, guys, Frog, you're a big international design company. Why would you want to work with UNICEF on this? We'll make sure that your designers get to the field. They will stay in the field for 3 weeks. They will work in some of the most difficult places in the world, and they will come back to your studio in Austin feeling like the most amazing thing has ever happened to them that has happened to them, which they did. So we sent these 3 designers with our developers and with the Zambian guys up to northern Zambia. They spent about 3 weeks looking at user behavior, and they started building out a system with these health extension workers for getting results back more quickly. And it's a pretty, I mean, it doesn't, you could think of that system from here, right? The result is produced at the Capitol, and then you can text it back to the health extension worker, right? So that just halves the amount of time for the result getting back to the health extension worker. That's not rocket scientist. We could have thought of that here. The thing that they saw when building it was that there was another need. And the other need was for these health extension workers to make sure that mothers would go back to the clinic for the second visit, for a third visit, and to make sure that you have this tracking of mothers over the first 6, 12 months of the child's life. Again, this is not a new thing. It's not something that was like, wow, nobody ever knew you needed that to happen before. The thing that was new that the designers, these user experience designers and the developers were able to pinpoint was exactly in northern Zambia how you can incentivize mothers to come back in that particular context. And they built out a whole second system while they were there, working with mothers, working with health extension workers, that we could never have imagined from here. Okay, so that's done. That's working in a few clinics. How do you get it to scale? No amount of technology can ever fix a broken national health system. It doesn't matter how much cool stuff you dump in, how many phones you give out to health extension. It doesn't matter. It's a human problem. And the human problem is partially at the levels of decision makers in a government. How do you convince them that this thing makes sense, that it's cost effective, that it works? And you do that by bringing in people who can do proper monitoring and evaluation with the project. So the third group that we had in this project was academia. And academia who were involved in this was everybody from Columbia University's SEPA program to some folks from Tufts. And they worked with our designers and our developers and the health extension workers at each point to establish a baseline. Because this stuff is so new that there is no baseline. Nothing exists before. So at the end, you've served 1,000 people with a health solution on mobile, and it's like, great. Well, nobody was served with that solution before, so it's 1,000 times better. No, it doesn't make sense. You have to have a rolling baseline, and the people who know how to do that are in academia, and they're experts in doing monitoring and evaluation of projects. At the end of this, you've got a project that's open, that you can replicate and adapt in any other country that you want, that's been built on user principles, on the needs of users, and that has a firm set of monitored and evaluated things that worked and didn't work that you can go and take to a national health system and sell as a whole package. And so that's organizational change in the sense that it's not a pilot, it's an effort to use some of these new technologies at the government level, at a national level, and really take them to scale. And I think that's one of the most exciting prospects, is that we can actually advocate for open public mobile solutions to governments and to help them get real-time data to make better decisions for their populations.
Wow.
Sorry, that was a lot, but
no,
that's what happens when you don't have slides.
Yeah, that's great. Appreciate it. By the way, the hashtag for this is Heyman Mobile. Andrew, what do you need to say to this? What about organizational change? And then Nadim, I want to get your input on same.
Yeah, I think Chris is absolutely right. That's what you see there is organizational change management applied to a big institution. We also have this problem that happens when you get lots and lots of organizations that are trying to do the same thing. So a great example of that is actually in the water space. Could I just ask you to just click ahead one slide? I'll just show you this one thing. This is from a guy named Ned Breslin, who's the CEO of an organization called Water for People. And this is one of the very best water health and sanitation organizations in the world. They walk past broken wells that were dug 3-5 years ago to dig new wells in the same communities. And nobody had any idea that another organization had been there just literally a year or two before and had put in a piece of infrastructure. And often what happens with these sort of things is you get actually local organized crime facilitating the digging of new wells because it's like a construction job. So they actually have an incentive to break the well once it's put in place. So you get the lovely, cool Western celebrity who comes in and cuts the ribbon and has the emotional experience, and they take the photograph, and they get back on the chopper, and they never are seen again. And what happens the day after? So the day after problem for all of this work is another area where mobile services can provide something really powerful. And I'll just show you, if you just show the last slide here, is this thing I'll show you behind me. This is called Flow. So this is a mobile, crowdsourced well health map that shows the health of every single well in a particular catchment area. So what they're and they're using this in 60,000 communities. They launched it in October. Okay, so they went from 0 to 60,000 places in a matter of months. So this is real scale. This is the question of how do you get to scale, right? The fact that it's open is an accelerant of its moving to scale. The fact that there's a common framework for taking the data to show the health of various interventions is an accelerant of its getting to scale because nobody wants to dig the same well twice, right? Nobody wants to solve the same problem twice, and you can't get any sense of how these things are doing. So the use of mobiles, not just to do what Chris said, but actually to provide an ongoing snapshot of a system that is in a state of dynamic disequilibrium, that is always changing, that's constantly updated and added to by thousands of people, will make all of our interventions and all of the philanthropic interventions that we put in place to do this kind of work much more effective, because we can actually chart the resources to where they're needed most. If you go to, I think, just go to waterforpeople.org, or just go waterforpeople.org and look at, type in Water for People Flow. I don't have the URL off the top of my head.
Nadim, you're research director also as co-founder of your organization. What kind of numbers are you finding in terms of effectiveness and proliferation?
Right. So just before I get into numbers, I really do have to stress the importance of monitoring and evaluation. So as research director, that's basically what I'm responsible for. We've been working with SCPS students to send them to different implementation projects and help them set up rigorous studies to evaluate what's happening against controls. So I have, I guess, a billion comments based on things that have been said, so I'm going to try and go through this systematically, and I don't have slides either. But what Chris was saying about replication and how it's important to understand what was done at a particular implementation so that can be scaled, I think that's of quintessential importance. At the same time, I think, as a cautionary note, it's important to interpret the context. A solution that works in Malawi, for example, might not be appropriate in Dhaka, and we've seen that over and over and over again, where we've done a study in one context and then tried to replicate something similar in another one, and it doesn't work. So while I think that monitoring and evaluation are extremely important and transparency of implementations is important, that needs to be qualified by the particular environment and the particular circumstances under which that pilot was conducted. And there are two other things I wanted to touch on, because I have to leave, unfortunately, in about 15 minutes. The democratization of information and of the tools that we're building is also extremely important. I can't emphasize how many times we've encountered a partner that has approached us after trying to rebuild a tool that basically already exists. There's a partner in India recently that has been trying to have their developers develop an entire electronic medical record system from scratch to bring in information from cell phones. There are 3 tools like that exist and perform those functions almost perfectly in many different contexts. And I don't know the solution for how to get that information out there. We're promoting our own tools as much as possible by blogging, through social media, and through publications and journals. But I wonder, and this is, I guess, a problem that remains to be solved, what is the best way of communicating this information? Even if you are being open and transparent about what you're doing, how do you actually disseminate that information to everyone so that they know about it? And then one other thing that I wanted to talk about, Andrew, you mentioned 2 things that really resonated very strongly with me, about behavior change induced by mobile tools, and then also about the synergistic effect you can see when mobile tools are combined with things that are not inherently mobile. I just wanted to, I know this isn't necessarily related to the current discussion, but it's, I think, extremely important. Something that we've been seeing that is not necessarily related to behavior change, but more related to a change in potential skill sets. We've seen a lot of this in the healthcare industry, and I imagine, Courtney, you could speak to this with respect to politics, but, social media tools as well as mobile tools can transform, an average citizen into an amateur journalist, into an ad hoc political leader. In the context of healthcare, it can transform an untrained medical semi-professional into a true lab technician. There are a whole suite of diagnostic prototypes, for example, that enable you to use a camera phone to run a rudimentary blood sample, and even have a software algorithm run on this to diagnose malaria or bacteremia and things like this. And so a health worker who doesn't have much formal medical training, much less any training as a lab technician, can conduct a lab test from the field without having that training. And so I think we're seeing this sort of shift from semi-professional to newly found abilities as a professional in a lot of